All right, so we're on to our last part of the session today. So what we've got next is two pre-recorded speeches. The first is from Dr. Seth Berkley, who is the CEO of Gavi. And the second is from Dr. Krishna Udayakumar, who's the founding director of the Duke Global Health Innovation Center. Dr. Krishna will be available for Q&A online afterwards. So we look forward to that. But we'll just please go ahead and play the recordings. Thank you.
Distinguished guests, ladies and gentlemen, thank you for inviting me to speak here today, and my apologies for not being able to join you in person. As you all know, organizations like Gavi have worked long and hard to improve access to essential medical interventions like vaccines, therapeutics, and diagnostics for lower-income countries. In our case, access to vaccines, although we are now also looking at diagnostics for some vaccine-preventable diseases. In this, we have, in no uncertain terms, been incredibly successful. Since we were created in 2000, Gavi has helped vaccinate more than 1 billion additional children and prevented more than 16 million deaths, and that's excluding COVID. Today, we help protect roughly half the world's population from deadly and debilitating infectious diseases. That was only made possible through equitable access to vaccines and the expansion of routine immunization to lower-income countries. But as the last few years have shown, when it comes to pandemic vaccines, that model can break down, revealing significant chinks in our global health security armor, ones that we still urgently need to fix. When COVID struck, it quickly became clear that global solutions would be needed if we were to ensure that people in lower-income countries did not get left behind. This led to the creation of multilateral partnerships like COVAX and ACT-A to bring all stakeholders together around the common cause of providing equitable access to therapeutics, diagnostics, and vaccines. With vaccines, we have been extraordinarily fortunate because thanks to the incredible work of the scientific community and industry, we didn't just get one safe and effective vaccine, but dozens of them. Because of this, COVAX was able to make equitable access to COVID vaccines possible, delivering its first doses to lower-income countries just 39 days after people in high-income countries received their first jabs. Today, COVAX has delivered more than 1.8 billion doses to 146 economies, with over 1.6 billion of them, roughly 90%, going to the 92 lower-income countries that would have otherwise struggled to get access to them. This extraordinary effort, the largest and most complex global deployment of vaccines ever, has helped these countries fully protect 51% of their citizens. This compares to a global average of around 63%. But how far we have come bellies the struggle of the journey. Despite having created a mechanism that would remove the financial barriers to these vaccines, and even with the backing of more than 195 governments and industry, we faced immense challenges along the way. Intensive vaccine hoarding by wealthy nations, as well as export restrictions imposed on vaccines and vital components needed to manufacture them, and a lack of transparency by manufacturers have all created huge bottlenecks in the global supply of COVID-19 vaccines. This significantly hindered equitable access, particularly for developing countries, creating delays that ultimately cost lives. Next time, we simply cannot afford to have that happen again, and make no mistake about it, it is an evolutionary certainty that there will be a next time. The risk of future pandemics is actually increasing, driven by global trends like climate change, urbanization, human migration, and conflict. The latest research suggests that in a given year, the probability of a COVID-scale pandemic occurring is now around 2%. That means somebody born now has a 38% chance of experiencing one in their lifetime. The bottom line is that we need to be better prepared. Even as COVAX continues to deliver vaccines and help countries that have been struggling to turn doses into shots in people's arms, and as Act A embarks on its next 6-month plan to bring COVID under control, we need to be thinking about the next one before disaster strikes. While COVAX has protected hundreds of millions of people, it only worked because it was built on global health networks that were already in place before COVID, drawing on pre-existing resources, expertise, and infrastructure to mount a rapid global response when needed. However, doing so stretched these agencies to the limits. If they had had surge capacity and at-risk contingent financing built in, valuable time would not have been lost mobilizing COVAX and raising the billions of dollars it needed. This would have enabled the response to be faster and more impactful. Taking calculated risks are also necessary in a pandemic. For example, putting in place orders for vaccines that we do not yet know if they are going to work. We had to work with our donors and stakeholders to accept a higher risk appetite, something that many other organizations might find difficult. But again, a pre-agreement on this would mean less delays. At the same time, we need continued investments in solutions that are continually working to help mitigate the threats posed by pandemics, not just during a crisis, but on an ongoing basis. Expanding access to routine immunization in lower-income countries is one good example of this because it helps to create stronger health systems and more resilient primary health care. Gavi's mission to protecting the most vulnerable children in the world through routine immunization makes this possible because not only does it prevent outbreaks of vaccine-preventable disease, but it also creates a platform upon which other critical health interventions can be built. This helps to improve pandemic preparedness and response because usually the first point of contact people have with the health services when they get sick is with primary health care, and therefore it is critical to infectious disease surveillance. So by continuing its efforts to reach more children, in particular zero-dose children, those who do not receive even a single dose of a basic vaccine, who often live in some of the most marginalized and multiply deprived communities, Gavi is helping to improve our early warning system by addressing some of our biggest global health security blind spots. And of course, in addition to this, the work Gavi does in maintaining stockpiles of vaccines for epidemic disease like yellow fever, Ebola, cholera, and meningitis, not to mention our work to strengthen health systems, plays an important role in improving global health security. In fact, about 70% of Gavi's current phase funding helps to build pandemic preparedness and response capacity in the countries where we work. However, even with all these pieces in place, another key learning from COVID is that there's a dire need for vaccine manufacturing to be more diversified so that all regions have greater supply resilience, particularly Africa. Currently, Africa produces less than 0.1% of the global supply of vaccines. So when COVID came along, this lack of regional vaccine supply across the continent in the face of vaccine hoarding and export restrictions we witnessed led to Africans dying because of delays in access to doses. With more than 30 new vaccine manufacturing initiatives underway in Africa, led by the African CDC's Partnership for African Vaccine Manufacturing, and with backing from G7 and EU leaders, as well as the Pandemic Pact spearheaded by the German government, this now looks set to change. However, this kind of diversification brings with it both challenges and opportunities. The main challenges lie in how we do this without disrupting the global vaccine ecosystem that we have all worked so hard to create and which has already saved so many lives in lower income countries. But there are also great opportunities to forge new partnerships that can help boost the global production of routine and regional vaccines and improve product profiles while also increasing supply resilience for future pandemic vaccine needs. Gavi has a lot of experience in this area. When it was first founded, it just had 5 suppliers, which were mostly based in Europe or North America, whereas today it works with 18 manufacturers, even without the new COVAX suppliers, half of which are in Southeast Asia and only 7 in Europe or North America. Given our experience here in helping to shape markets and the fact that we are the world's largest purchaser of vaccines and the biggest supplier to African nations, Gavi will work with industry and governments to play its part. But beyond Africa, creating greater supply resilience in all regions remains important, not just for pandemic preparedness, but also for improving access to routine immunization and protecting people in lower income countries. Ultimately, achieving equitable access to life-saving medical interventions require the global partnerships and multilateralism. We all have our roles to play to ensure that in the future, no one is left behind. Thank you.
Good morning. It's a great pleasure and privilege to join you today and to follow Dr. Seth Berkley, who has been an inspirational leader at Gavi, the Vaccine Alliance. I'm sorry to not be able to join you in person for this fantastic conference, but look forward to following along virtually. Over the next few minutes, I'll provide my perspectives on the future of access to diagnostics, therapeutics, and vaccines for low and middle income countries, based on our extensive research and policy engagement over the past 2.5 years. Through the Launch and Scale Speedometer, we have been tracking the COVID-19 vaccine marketplace in real time for over 2 years, and in fact released our first report more than 2 years ago in November 2020, which made 3 main points. First, it raised a red flag that high-income countries and some middle-income countries with manufacturing capacity had already cornered the market before any vaccines were authorized anywhere in the world. Second, it predicted that under the current dynamics then in place, even with COVAX, low-income countries just wouldn't be able to keep up in the competition for timely access to vaccines. And third, it pointed out significant distribution challenges across low-income countries in addition to supply constraints. All of those trends and points, unfortunately, have played out over the last 2 years. Secondly, through the COVID Global Accountability Platform, or COVID GAP, we have aimed to serve as an independent source of insights and actionable recommendations, convening key stakeholders to galvanize actions and collaborations, and also to strengthen transparency and accountability for pandemic response and preparedness. In that context, let's look first at where we are with the COVID-19 pandemic and what we've learned over the last 2.5 years. Secondly, how we might apply those lessons to preparedness to strengthen systems and capabilities, as well as to ensuring a more equitable and effective response for the current threat as well as future ones. Where are we today? Well, almost 3 years into the pandemic, we've had more than 630 million reported cases, more than 6.6 million reported deaths, excess mortality likely well over 20 million, and we're still averaging more than 1,500 deaths every day. By any measure, this pandemic is not over. The global response over these past 3 years has included breathtaking pace of new scientific achievements, unprecedented scale-up of global vaccination campaigns, and at the same time glaring inequities that have left behind many of the most vulnerable populations around the world. Less than 2 years after the initial rollout of COVID-19 vaccines, almost 13 billion doses of vaccine have been administered. Over 68% of the world's population has received at least 1 dose. And yet the inequities are vast and stark. 74% of people living in high-income countries have completed a primary vaccination series, compared with only 19% in low-income countries. That gap is even larger when we start to look at booster uptake. Unfortunately, the same dynamics are playing out with access to diagnostics and therapeutics. For example, if we look at average daily testing rates for COVID-19, the rates are 50 times higher in high-income countries than they are in low-income countries. When it comes to therapeutics, most low-income countries and lower middle-income countries around the world are still struggling to access therapies like Paxlovid, which has been available in high-income countries for almost a year. If we look back at the last 3 years, I want to highlight 5 lessons that we've learned from our analysis as well as those that others have undertaken. First, it's clear that almost every country was unprepared, and we also have underappreciated the value of political leadership. The countries that were better prepared were those that dealt with threats more recently, whether those were Ebola, SARS, or other global health threats. It teaches us that global health security capabilities have to be exercised and practiced, not just put on paper. At the global level, we also clearly saw that there was not enough participation and leadership from stakeholders in low and middle income countries, and that political leadership proved to be much more important than scientific breakthroughs and public health technical skills. Throughout the pandemic, we've seen the coupling of major scientific achievements to failures of political leadership that prevented those breakthroughs from impacting the lives and health of those we're trying to serve. Secondly, we saw consistently that national security concerns override multilateralism during crises. Endlessly, we've heard that no one is safe until everyone is safe, which is undoubtedly true, yet every single country made decisions based on short-term self-interest, even when the overall outcome would have been much better with collaboration and cooperation. This includes everything from export restrictions, which we saw in the US, Europe, and India, as well as travel restrictions around the world that were for the most part ineffective. We need to learn from that our global health security architecture must be designed to account for such behavior rather than hoping for cooperation during crises. We saw similar breakdowns in global supply chains that were previously optimized for efficiency rather than for resilience to meet crises. The third lesson we've learned is that public health messaging and even an emphasis on economic return on investments were not enough to unlock adequate financing in urgent times in the midst of a pandemic. While G7 nations poured trillions of dollars into their own domestic health and economic response, the multilateral COVID-19 response has struggled to raise adequate funding for over 2 years. In 2020 and 2021, the ACT Accelerator raised $17.8 billion against a request of over $33 billion. And in this past year, 2021 into 22, it raised $5.9 billion against a request of more than $16 billion, with a significant shortage that continues. Third, we've learned that equity has to be more than a concept, as we saw breakdowns in equity at all levels: global, regional, national, and subnational. It's taught us that we need to be able to capture and track high-quality, disaggregated data at a subnational, national, regional, as well as global level to be able to fully understand our progress toward equity and adjust our response accordingly. A commitment to equity also means focusing on the highest risk, most vulnerable populations, in addition to focusing on national targets and coverage rates. And fifth, what we saw was a continued underinvestment in the distribution, delivery, and demand generation capabilities necessary to match supply for therapies, diagnostics, and vaccines. For example, in the first year of vaccination, we saw that the major constraint was global lack of supply, both in terms of total supply as well as allocation in an equitable sense. But in this past year, the second year of vaccination, the majority of our constraints have been in the distribution, delivery, and demand generation phase, where we failed to invest adequately and in a timely way. What we now see is a glut of vaccines that's resulted in hundreds of millions of wasted doses at the same time that we're seeing poor coverage rates because we lost the window of opportunity to really ramp up vaccinations all over the world. And we're now seeing the same issues play out with both treatments as well as capabilities to invest in test and treat, which is what's going to be needed both for COVID-19 during future surges as well as for future global health security threats. So from those lessons learned, what can we do in the future? I will talk about 4 specific recommendations on how we apply those lessons. First, we have got to reform the governance of global health security going forward. That means, first and foremost, more global leadership from the global south. And it also means that we need to focus on country-driven goals supported by regional and global organizations rather than the other way. The ACT Accelerator, when compared with having nothing in place, certainly provided valuable coordination as well as fundraising capabilities. But this should also be a wake-up call that we need to have better plans in place for both decision-making as well as coordination for future threats. And that must be coupled to real metrics, targets, and measures of accountability. Secondly, we need to fix financing. The multilateral response, as we just reviewed, struggled for adequate financing for more than 2 years. And the systems we now have in place continue to struggle. For example, the Financial Intermediary Fund for Pandemic Prevention, Preparedness, and Response has a goal of raising over $10 billion per year. And to date, the commitments in totality have been less than $1.5 billion, much below what we need it to be. That tells us that we have to come up with new models for financing beyond aid and beyond our traditional model of regular replenishments. One specific idea that we need to pursue is this idea of day zero financing, having in place a pandemic advanced commitment facility, such as the one outlined in an IMF working paper from earlier this year. Third, we need to really think about health systems as a key enabler of pandemic preparedness as well as response. And that means investing in capabilities related to primary health care, including workforce of community health workers and other frontline health professionals, including stronger supply chains and surveillance capabilities, those same capabilities that are going to make us more prepared for the next variant or the next global health security threat are also the ones that are needed to make sure that we're improving our rates of routine immunization, that we're offering access to essential health services and technologies for everyone in an equitable way. And to enable those health systems, we also have to invest in data systems. They are the key enablers of pandemic prevention, preparedness, and response, and in fact for health systems more broadly. And fourth, we have to think about regionalization. We need a level in between the national response and the overall global response. And what we've seen over the last 3 years as one of the true bright spots has been the maturation and the leadership provided by the Africa CDC as a regional body across the African continent in partnership with the African Union. Such regional coordination and decision-making are going to be critical for the future of pandemic preparedness and response. We also have to see regionalization in terms of manufacturing, and that is going to require access to intellectual property, but much more than that. It's going to require technology transfer, financial investments from both the public and private sector. It's going to require capacity building and building of human capital, new supply chains, as well as, importantly, regulatory support and oversight at the national and regional levels. This is where the movement toward establishment of the Africa Medicines Agency is going to be incredibly important. In essence, we have to build a new ecosystems for critical health products that are driven more by national security interests than they are efficiency of manufacturing commodities. And to make that happen, we have to figure out how to create sustainable demand and financing, not just investment into the supply. In summary, I want to instill that we're at a pivotal moment in time. We can either fall back to the same cycle of panic and neglect that we've seen for too long, or we can seize the opportunity that's in front of us. There are many potential developments underway, from the negotiation of a new pandemic instrument to a relooking at the international health regulations, the establishment of the Financial Intermediary Fund, a potential for a Global Health Threats Council, the high-level UN meeting to come next year, a re-energizing of the Global Preparedness Monitoring Board, as well as an ongoing global health security agenda. What's not clear is how many of those pieces are actually going to fit together into a cohesive architecture for global health security. We all know that there will be future threats. The time is now to come together to make clear decisions and investments that help secure our collective future. Thank you for the opportunity to join you today.